and welcome. I'm Jeunesse Castonguay, VP at Clarius. Thanks for joining us for today's live webinar, Pragmatic MSK Ultrasound, Dynamic Assessment of the Shoulder. You're among 1,800 clinicians who registered for this popular session, including physical therapists, orthopedic surgeons, primary care physicians, emergency doctors, pain management experts, sports medicine clinicians, chiropractors, physiatrists, and many more. Welcome and thank you for joining us today from all corners of the world. It's been wonderful to partner with Sonoskills to bring you today's educational event. In a moment, we'll be joined by renowned educator, Mr. Mark Schmitz, who will be teaching us anatomy, sonoanatomy, technical scanning skills, and pathologies common to the shoulder. You'll learn MSK ultrasound scanning skills that you can use on your next patient to make a confident diagnosis and expedite the right treatment plan for a more rapid recovery. A quick housekeeping note, please do use the Q&A icon at any time during today's session to ask questions, which we'll address in a live session following the presentation at the top of the hour. Let me now introduce you to your host for today's webinar. Dr. Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a busy academic teaching hospital in Vancouver as an emergency physician and serves as chairman of our medical advisory board. Welcome back, Dr. Frankel.
Thanks, Jeunesse. This is a really interesting topic for us in acute care where we're constantly seeing musculoskeletal injuries, and I'm really excited to kind of get into the depths of it. To set the stage of our discussion, I wanted to kind of review a few highlights in the literature that kind of highlight specifically around dynamic testing. This first paper was a review article that really highlights when looking particularly at subacromial impingement, patients who are experiencing symptoms associated with that syndrome, how essential dynamic ultrasound specifically is in addition or beyond other more static imaging techniques for identifying the pathology of subacromial impingement syndrome and really figuring out exactly how and why patients are experiencing those symptoms. This next article really shows how a proper dynamic study enhances the diagnostic quality of shoulder ultrasound. So where shoulder ultrasound is already a very useful modality in the static sense, ultrasound provides this really unique ability to evaluate the structures in a dynamic setting, really capturing the way that the patient is trying to live through their pathology and highlighting pathology that might not even be evident on the static exam alone, and really giving it stronger diagnostic powers. And lastly, this position paper from Europe really highlights how integration of a dynamic assessment into ultrasound protocols can really push the key differentiators for ultrasound as a diagnostic tool. And specifically around the shoulder is one of the places it really shines in this additive ability to do dynamic studies. So before we jump into the deeper topic here and learn a bit more how-to, we wanted to kind of put out this poll. We know people are from all over the world and all walks of ultrasound use in their clinical integration, and want to know which of these challenges have you encountered with patients who present with shoulder pain? Have you experienced that there's too broad of a differential? Maybe you mistook the diagnosis or encountered ineffective treatment or unclear progress? Why don't you go ahead and click any of the ones that really apply? And we will close out the poll here. Let's see where people are at. So really across the board, and these are experiences that all of us have had in trying to deal with patients who present with shoulder pain. And we're going to learn more about how ultrasound specifically can really help resolve these pain points. And we're so happy to bring back Mark Schmitz, who after obtaining a master's in science focusing on musculoskeletal anatomy, completed numerous courses and attended conferences on the topic, and then developed his own course and Sonoskills back in 2010. Since then, Sonoskills has taught its courses on ultrasound diagnostics in 30 countries, and he heads a team of 22 expert trainers, where he teaches next to managing Sonoskills, also the foundational course and some intermediate level courses. And we're really happy to have Mark back because of his special interest in the shoulder joint. We can't think of anyone better to show us a little bit more about dynamic assessment. Mark, I'm going to hand it over to you.
Thank you very much, and thank you, Clarius, for the invitation to present, and thank you to all the viewers at this moment all around the world. Yes, so I'm really happy to be here. I think it's an important topic. Like mentioned, I'm seeing lots of shoulders in clinical practice. I have a shoulder day. I see, I think, 32 shoulders in a day, 50 minutes per patient. And what I do is diagnostic and also interventional ultrasound. And yeah, so what I'm doing there, I'm also trying to convey today to you. We teach thousands of people every year over online and hands-on courses, that many people, they make images and they stay on one single spot and they check, yes, tendon looks okay, go to the next transducer position, but they don't tend to screen the whole region dynamically. So the sonographer or the clinician dynamically moving, but also the patient dynamically. So activating muscles and let the patient move. And that is not being done a lot. And I think that lots of crucial information is being lost there. So we always say that shoulder ultrasound is not something static, but it's definitely a dynamical assessment. There's nothing to disclose, so there are no financial ties to anything I relate or present in this presentation. Like mentioned, I'm Mark, founder of Sonoscales. What we do is we teach many MSK healthcare professionals all around the world. And yes, 30 is, I think, correct, but by now, not 22 trainers, but we're somewhere around 50 expert trainers who all speak their own languages, all have a different professional background and located in various countries. If you go to ultrasoundcases.info, a Sonoscales website, it's free to use, and there are more than 7,000 pathology cases there. So you can check it, you can use it, and to steepen your learning curve. So if we are talking about the start of the shoulder protocol, let's always start with the biceps, the long head of the biceps, which you can find within the two tubercles, the lesser and major tubercle. And in between, you can find the groove containing the long head of the biceps tendon. And then you can see a rough area right here. And that's the attachment point for the pectoralis major tendon. So the biceps tendon is located in a groove and stabilized by various structures. One of them at the sulcus level is the pectoralis major. And here you can see a few fibers attaching to the greater tubercle. These are a few fibers of the subscapularis. Important to know, because if this part of the subscap is torn, then a biceps might luxate to medial. We're going to follow the biceps to distal until we have a point that you can see the pectoralis major tendon. So this is the pectoralis major tendon, quite broad, comes from medial, and together with a different structure, the latissimus dorsi, they also stabilize the biceps tendon. At this level, this is the first point where we are going to do a functional check. So we're going to ask the patient to make an external and internal rotation. And with that, you give a stretch to the biceps. And this is a spot which is where you can see tearing of the pectoralis major tendon or the latissimus dorsi, and in many cases also affecting the long head of the biceps. It's a real interplay. They work together and they should be regarded as a functional unit. Once we've checked this functionally, with external internal rotation, we can continue following the biceps to distal, looking at the musculotendinous junction and also the muscle fibers, and with creating a resistance, a flexion of the elbow joint, and making an antiflexion with resistance, you can test the biceps muscle and see whether there are some small tearing in the biceps muscle or if the musculotendinous junction is affected. So if in doubt, especially if in doubt, always ask a biceps contraction, or that tearing and damage to the biceps muscle can be more apparent. Here you can see a cadaveric slide with the latissimus dorsi. So many people think latissimus dorsi near the long head of the biceps. That can be right, but it is right, as you can see, because this is the bicipital groove containing usually the biceps. This is the attachment point for the pectoralis major, and the other side is the latissimus dorsi, and the biceps is really in between those two muscular and tendinous structures. After we've seen the biceps distally, we're going to follow the long head of the biceps back to proximal, and then we're going to try to find the biceps in the rotator interval. And 2 years ago, I did a webinar also with Clarius, also a little bit about the rotator interval, and this webinar might be available on clarius.com. So you want to check that out. But in the rotator interval, we can find the long head of the biceps. And this is a spot which is also really important to check dynamically, because this is a spot which is highly sensitive to instability. The biceps moving over the surface of the humeral head. And with that movement, this instability of the tendon creating a cartilage defect to the bone, to the humeral head, but also creating damage to the tendon, leading to a tendinopathy and sometimes partial or even complete tearing. This is the cross section of the long head of the biceps. You can see that the long head of the biceps in this rotator interval, which is depicted here, this rotator interval is created by the coracohumeral ligament. And this coracohumeral ligament stabilizes the biceps together with the SGHL, which is the superior clinohumeral ligament. And in the end, in the ventral shoulder, we go to the subscapularis tendon. The subscapularis is really broad, so don't stay too proximal on a subscap, because a lot of people miss damage, injuries to the more distal subscapularis. So make sure that you fully screen the whole tendon from proximal to distal. And then also a functional assessment looking at the subscapularis in relation to the coracoid process, where you might see a impingement between the coraco and in the coracohumeral outlet, impingement of the subscapularis tendon, or maybe also a bursa, which could be the subacromial or maybe even the subcoracoidal bursa. Here you can see an overview of the bursas. So this is from a view, eagle-eye view. You can see that this is the humeral head with the subscapularis tendon and musculotendinous junction. We can see the outlet between humerus and coracoid process, so the coracohumeral outlet. And in this area, we can find 3 bursas, which is the subacromial bursa, subdeltoid bursa. This is the subcoracoidal bursa, and then we have the subscapularis bursa. So this you check dynamically, functionally in this coracoid process region. So I believe I have a clip for you in the next slide, which shows you the scanning of this whole region of the long head of the biceps, the rotator interval, and also the subscapularis tendon. First, this slide, that's here you can see the relation of the subscapularis to also the joint, the labrum, the clinohumeral capsule, and also again the bursa. So this is of course a cadaveric slice. Then the bursas, they open up. Usually you won't see them that well, unless maybe they are pathological and filled with a fusion. And in this coracoid process region, we can have a look at a number of pathologies and number of structures. They fall a little bit out of scope of this talk. Now we're looking at a foundational protocol, but there is so much to tell about the shoulder. There are so many structures there, so there's always more to learn. So we could also do this talk maybe next year from an advanced perspective, and then looking at, for example, the ligaments, the coracoclavicular ligaments. But for today's topic, we will focus later on the coracoacromial ligament and the coracohumeral ligaments. Okay, so here you can see the demo, first placing the transducer on the ventral shoulder, toggling the transducer in order to make sure that anisotropy is avoided, and then following the biceps down to distal. And now you can see from the left side a horizontal tendon. This is your pectoralis major tendon, and this pectoralis major needs to be thin, strong, hyperechoic. Here we can see the long head of the biceps tendon. And now I'm going to externally rotate the arm of this model. And then you can see that this is the latissimus dorsi right here, close to the bone. This is the pectoralis major. And in between, this is the long head of the biceps. And like mentioned, this is a sensitive spot. There is the tendon. Right, and we're going to search for the integrity of the tendons and the insertion to the bone. So let's look a little bit more to distal into the muscle belly of the biceps. You can always compare the long head of the biceps muscle belly with the short head of the biceps. They're aligned next to each other. They should be similar in echogenicity, especially with large tearing. You will see changes to the echogenicity. The torn muscle or the torn tendon will be much more hyperechoic. With making a contraction, you can also see the tearing of a tendon and muscle much better. Now the transducer has positioned and shifted to proximal. This is the rotator interval. Observe the oblique angle of the transducer on the ventral shoulder because the tendon tends to go to medial to the glenoid cavity. And here we can see the long head of the biceps right there, wrapped in the coracohumeral ligament. And now in an extension, the patient is making a internal rotation and external rotation. And what we want to see is that the biceps is following the movement of the humeral head. So they both need to move in the same direction. If it's an unstable situation, you will see that they will move in the counter direction. So they follow a different path. If there is an instability there, you also might see some erosions to the bone and to the cartilage of the humeral head. Now I'm going to search for stability of the tendon in the groove. So observe that I'm again making an in and external rotation. If the biceps is luxating, and that could be due to a tearing of the subscap tendon and also the coracohumeral ligament, then the biceps might pop out to medial, which in this case is the left side of the screen, because here you can also see the subscapularis, so we know that that's the medial side. And there is so if the biceps is luxating, you need to look at several structures, the subscapularis, but also the superior glenohumeral ligament, and of course the coracohumeral ligament. Now we're going to make an external rotation and leave it there. And now the subscapularis unfolds, and we're going to check the tendon and the insertion of the tendon to the lesser tubercle. And as you can see to the transducer, I'm following the tendon of the subscap over a whole stretch. Don't forget that many people stay too often proximally, and you need to also look at the distal parts of the tendon. Once having looked in a longitudinal perspective, then we can also have a look at the subscap in transverse. And again, moving the transducer from proximal to distal in order to really know whether if the tendon is really intact in this insertion. And then if you've located the full tendon, follow the biceps from lateral to medial to its musculotendinous junction. I'm rotating the transducer back to a longitudinal position for the subscapularis. I'm trying to locate the coracoid process right here. And again, external, internal rotation to see whether in this outlet between coracoid process and humeral head, there's something there, a space occupying process. Think of calcification, think of tendinopathy, think of maybe a bursitis of the subdeltoid bursa or maybe the subcoracoidal bursa. If it's a subcoracoidal bursa, it pops out. If you go to external rotation, it goes back underneath and hides underneath the coracoid process if you're making an internal rotation. If it's a bursitis of the subacromial bursa, then it really stays there no matter if you're making an inner or external rotation. Okay, so this was a functional assessment of the anterior part of the shoulder. Okay, so here we can see that the biceps on the left, in the left image, We can see a very large short head of the biceps muscle, which looks healthy, and we can see a hyperechoic long head of the biceps muscle. In a pathology, the biceps is torn and has difficulties in contracting, and then the biceps muscle becomes really hyperechoic and really is different from the healthy short head of the biceps right next to it. Here we can see the coracohumeral ligament in the rotator interval, and if you look closely, you can see a tear right there. And please also observe the cortical irregularity right here. So if you see these cortical irregularities, then this is definitely a sign of a instability of the biceps. The biceps is frictioning over the humeral head, causing erosion of the bone, and this is not a good sign, and this is called a chondral print sign. So if you're testing the rotator interval actively, you will see that the biceps needs to be following the movement of the humeral head, and if not, if it goes in the opposite direction, it causes erosion to the bone. So definitely check that as well dynamically. Here you can see an image of a calcification in the subscapularis. The calcification can clearly be seen as a hyperechoic white line with an acoustic dark shade underneath. And we can see that the thickness of this calcification right here does never match, does never fit into the space between the coracoid process and the humeral head. So if you see this is not able to slide into this space. So this will be an impingement on coracoidal level, so subcoracoidal impingement. Here we can see a subcoracoidal bursitis. So on the right side, you can see the coracoid process, and this is the bursa. And see how the bursa is being pulled underneath the coracoid process if the humeral head is moving. And this is really typical for these kinds of bursitis. You only see the subcoracoidal bursitis if the patient is making an external rotation. And in internal rotation, you won't see that. So let's continue to the next part. And I just want to invite everybody that also on sonoskills.com you can find many hands-on courses and also online ultrasound education, MSK focused. So you're much invited to drop by and look at our fantastic website. So when looking at the supraspinatus muscle and tendon, we know that the supraspinatus goes underneath a passage. That's the roof, the coracoacromial arch, which is formated by the acromion and the coracoacromial ligament. And then the tendon inserts to the greater tubercle. In between the tendon, here again, beautiful view, subacromial space right here. You can see the acromion, we can see the AC joint, we can see the tendon inserting to the anatomical neck and the greater tubercle. And of course, between tendon and acromion, we can see the bursa, the subacromial subdeltoid bursa. So the muscle of the supraspinatus is reinforced, and I don't know if you knew that the supraspinatus is a muscle with two parts. We have an anterior muscle and we have a posterior part. And the anterior part and posterior part really look differently. They have also a different function. And the anterior part of the muscle is reinforced with a large tendon which really flows into the muscle, a aponeurosis, which is lacking in the posterior part. The anterior part of the muscle is really carrying much more load and strength, also meaning that it's more reinforced with tendon, also meaning that if that part is affected in pathology, that's a problem. It's better to have tearing in the posterior part, which is more guiding the shoulder movements and helping, but not really carrying all the loads. So this tendon within the muscle is really important to look at if you want to search for fatty infiltration or atrophy of the supraspinatus muscle. In many cases, and maybe in, the first go-to in hospital settings is MRI to search for fatty infiltration of the supraspinatus muscle. But I would say that ultrasound is also something you can use to assess fatty infiltration. And I think it's especially helpful if you're working in primary care or you don't have access to MRI. It really helps you in understanding, should I refer this patient to an orthopedic surgeon for maybe cuff repair, yes or no? So I'm going to show you later on. Okay, so we've ended at the coracoid process and the subscap. Now, after having done this external-internal rotation for the subscapularis, I'm also going to look at the coracohumeral ligament. This is on top of the subscapularis, right there, the white hypercoic ligamentous tissue right here. This is your coracohumeral ligament, and this should be flexible and moving. And if it's stiff, it could be a sign of, for example, frozen shoulder. Now I've angulated the transducer and connected the coracoid process with the acromion, so it's more oblique. And now I'm not looking at the coracohumeral ligament anymore, but at the coracoacromial ligament right there. What we don't want to see in this functional assessment is that the ligament is bulging up so that there will be a convexity. No, that we don't want to see. We want to see that during movements, the ligament stays flat. The movements you could make is in a neutral position, internal, external rotation. You could also make an abduction, adduction, or maybe if we're talking about pitching or throwing, you could make an abduction, and then this movement, you could make an internal, external rotation. So a functional assessment of the coracoacromial ligament. You always want to check what's the reason of this convex ligament, and this might be a swelling of the supraspinatus or maybe a bursal effusion. I'm placing the shoulder in a modified pras position, hands on the back pocket, and first I'm going to look at the supraspinatus in transverse. This we can see right here. I'm going to circle around the convexity of the humeral head, looking at all parts of the supraspinatus. Again, supraspinatus is really broad, so don't miss a thing, because highly relevant structure. Of all shoulder patients, 80% has a supraspinatus problem, so this is especially an important part of the protocol. Also, in longitudinal plane, sweep the transducer or slide with the transducer from medial to lateral in order to see the full supraspinatus tendon. You also want to be on the lateral edge of the greater tubercle in order to see bursal fluid or effusion right there, calling a teardrop sign. Many people also forget to check that, because the bursa could look perfectly, but sometimes the effusion drops to the lateral side of the greater tubercle. Arm is neutrally next to the trunk. I'm going to modify my settings, placing the transducer on the acromion and greater tubercle, and then functionally assessing the supraspinatus gliding underneath the acromion. We can see that the bursa, subacromial bursa, and the tendon is gliding in this acromiohumeral outlet, or the subacromial space, and we don't see any buckling of the tendon. We don't see any effusion of the bursal fluids being pushed out the acromial space. After I have checked the posterior muscle, I'm going to check also the anterior muscle of this, or anterior tendon of the supraspinatus. So you don't see the acromion anymore. I'm now on the coracoacromial ligament in transverse, so transverse coracoacromial ligament, and we can see that this is the supraspinatus gliding underneath the ligament right there. This to me is this is not part of the most foundational protocols. I made it foundational because I think this is much more relevant than looking at the acromial impingement. much more patients, they have a coracoacromial ligament impingement. So that's much more relevant. Look where I'm placing the transducer. I'm placing it on the supraspinatus muscle and looking at the muscle in a transverse view. And what I'm trying to look at is this horseshoe shaped or this U-shaped bony configuration. And on top of that, we can see the supraspinatus muscle and transverse, and you can see this hyperechoic, crispy white line there. This is of the anterior muscle, the aponeurosis flowing into the muscle, reinforcing the muscle, and we don't see that on the left side of the muscle. Because this is the posterior part of the supraspinatus not being reinforced. And I'm making a contraction right there of the supraspinatus, looking how the supraspinatus behaves. If I see any tearing of the musculotendinous junction, damage to the musculotendinous junction, and fluids maybe popping up. If we're screening for fatty infiltration, there are 3 assessment points. Number 1, look at how crispy, thin, and hyperechoic the aponeurosis is. This is normal. With atrophy and fatty infiltration, it really blurs out and becomes a very vague structure. You don't see the crispy outlines. Checkpoint 2 is compare the echogenicity with the overlying muscle. That's the trapezius muscle. They should be similar. With fatty infiltration, the supraspinatus becomes really hyperechoic. Checkpoint 3 is how clear can you see the bone. If you have more fatty infiltration, the bone line will disappear or will be less visible. So those are your 3 assessment points. So looking at the rotator cuff, if looking at the supraspinatus and bursa together, we can see that this one is 0.9 millimeters, so almost 1 centimeter, and it needs to be 0.5 to 0.7, so 5 to 7 millimeters. That's the usual thickness. This is way too thick. This is a huge percentage. So this is a patient which definitely is prone to impingement, and you have to do your impingement test with this patient. Also at this level near the acromion, you can see that on the left side is the healthy side, the right side is the affected side, and you will see that this supraspinatus is higher, is thicker than the height of the acromion. So it's going over the acromion almost. So this distance does not fit into this subacromial space, so leading, of course, also to an impingement. This one does definitely fit underneath the acromion, and this one doesn't. Here we can see also a bursa. We can see that the whole complex of tendon and bursa is thickened, does not fit into the subacromial space. And on the right side, you can see that during the abduction, also the bursal fluid is being pushed outside to lateral because it follows the pathway of least resistance. And then you might see a collection of fluid effusion in the bursa while making this abduction.
How often do you see the bursitis here when there's an impingement syndrome?
Yeah, I see it. I think regularly. So it's a common finding. I see it on a daily basis. What I also see a lot is, of course, the calcifications like this one. Here we can see a calcification in this short axis view and also in this long axis view. And when I was, here we can see the acromion, and this is the tendon and long axis view. When I was moving with the patient to abduction, at the moment the patient said, "Ow, this is painful," I saw that the calcification was entering the subacromial space, being squeezed and creating a painful stimulus. And here we can see a full tear of the supraspinatus, totally retracted, leading, this always leads to instability, always leading to a cranial migration of the human head. And what happens then is that during abduction, there is a bone-to-bone contact, grinding of the bone and becoming erosive, the greater tubercle and also the humeral head. So in these patients where you don't see any cuff, you will see lots of erosion. And during this active abduction, we'll see and you will hear the grinding and you will see the erosion. This is an example of the supraspinatus more anteriorly. Like I mentioned, this is a highly relevant spot underneath the coracoacromial ligament. This is the transverse ligament. This patient is making an abduction, and we can see that the supraspinatus is being squeezed underneath the ligament right there. And yeah, this is an impingement at coracoacromial ligament level. And this is the same patient, posteriorly on the left side, anteriorly on the right side, same supraspinatus, but in this case, it shows that there is no impingement at the acromion, but there is an impingement at coracoacromial level. So you need to really scan both parts, anteriorly and posteriorly, to have a clue about, is there a supraspinatus impingement going on? And this is a swelling of the bursa underneath the coracoacromial ligament. And you can see that the ligament is bulging up. There is a little convexity. So this is a small friction underneath the ligament. Then we go to the last part of the protocol, looking at the AC joint and the infraspinatus. AC joint, yeah, synovial joint has a capsule, is being reinforced not only by capsule but also with ligaments, and of course trying to get the clavicula down. We all know that if there's a ligament tear, the clavicula might pop up, so there's real tension in that joint. And here we can see the reinforcements of the AC joint, the ligaments with the trapezoid ligament and the conoid ligament, and that we teach on an advanced level. Looking at the infraspinatus, please mind that the spine of the scapula has been cut away in this cadaveric image. So usually we would find the spine right here. So meaning everything below the spine, or in Latin, infraspina. So hence the name infraspinatus is the infraspinatus and also the teres minor coming and going together as a functional unit to the greater tubercle. And when scanning the infraspinatus, we also look at the bursa and also at the labrum in the posterior shoulder. And please mind that the infraspinatus really flows also anteriorly and superiorly to the greater tubercle, so blending together with the fibers of the supraspinatus. So that is also in many cases a pitfall that people think I'm on the supraspinatus, but in fact they're scanning the infraspinatus. So scanning the AC joint, we can see the width of the AC joint. So sweeping the transducer back and forth to check how regular the bone is, how smooth the bone is, how convex the capsule is, how wide the joint space is. And if there is a widening of the joint space, or if the clavicula is higher, then sometimes it's a result of a trauma, and we could do a stability check, a functional check. And we use the cross-arm maneuver for that. And the cross-arm maneuver, the hand is placed on the quadriceps, and now we're going to bring the hand towards the other shoulder. And with that, we're going to look at the AC joint, how it behaves, also returning back to the patient's quadriceps. And once I've instructed the patient is going to do it actively on his own, in this case. And then, like now, and then you want to see whether those bones, if they keep being aligned, and if there is an instability, you will see that there is a large movement of bones, compared to each other. And that is not what we want to see. So we definitely want to see a stable situation. Again, placing the hand on the other shoulder. Now going to the last bit of the demo, looking at the infraspinatus. Starting more ventrally at the insertion to the greater tubercle, and then right here. Again, the infraspinatus is very broad, is followed by the teres minor. So make sure that you follow the cuff in this posterior part of the shoulder, really from proximal to distal. Don't stay on one spot. Also the teres minor, look at the teres minor. I know it's not always that clinically relevant, but you might be surprised in those cases if it is. And if you don't look, you will miss it. Following the supraspinatus to or the infraspinatus to posterior, looking again at the internal aponeurosis of the infra. The story I mentioned with the supra also goes for the infraspinatus, also reinforced with the aponeurosis, and we're looking at the muscle, the musculotendinous junction, and also to the joint right here. Looking at the labrum, posterior labrum, and with this external, internal rotation, what we're doing is looking at the glenohumeral joint. Is the labrum intact? Does it behave properly? Is there continuity with the labrum? Is there continuity with in the musculotendinous junctions, or is there excessive effusion from the joint? So following the glenohumeral joint, a little bit more towards posterior. There we do an internal and external rotation. We can see the sphenoglenoid notch with the suprascapular nerve right there. Sometimes you might see effusions or a cyst pressing the nerve, causing for entrapment. In this case, you can see an anechoic zone becoming larger and smaller during this movement. That's a vein which is becoming bigger and smaller and collapses. But if there is a cystic formation, you will see this anechoic mass there. Even if you're external or internally rotating, it's always there. Now following the infraspinatus to transverse, looking at the muscle, and again looking at the aponeurosis of the infraspinatus muscle. This is also standard practice because I see so many infraspinatus muscle pathologies, even more than supraspinatus muscle pathologies. And same assessment points ago, check for the crispy lines of the internal aponeurosis, check if you see the bone, and lastly, check whether the echogenicity of the muscle is the same as the overlying muscle. And which muscle is this with the infraspinatus? Do you know? Think for a second. 1, 2, 3. What was it? The trapezius? No, it wasn't. It was the deltoid muscle. So different location, different muscle, but the concept of having similar echogenicity is the same. So a few pathology slides, and then it's back to you, Aran, is that in the left image, we see a normal AC joint. In the right image, we can see a instability during this crossover sign, and measuring the biggest gap. And you can see a clear difference between both sides, indicating a ligamentous problem of the AC joint. And it's not only about widening, but also the height of the joint. We can see that the clavicle left is much higher than the clavicle on the right side, also leading to instability. And this is also easy to see during these dynamical movements. And here we can see a muscular problem, a tearing of the muscle, also fatty infiltration of the infraspinatus muscle. And while contracting this infraspinatus under ultrasound guidance, you will see that the muscle is dysfunctional and that not much contraction is happening due to the fatty infiltration. And here you can see an example of a misalignment of the glenohumeral joints. We can see a high difference between the right side and also the left side. This is a dorsal luxated glenohumeral joint, yeah, you can see it because of this high difference left to right. So if we have a Q&A in a few moments, but if after the webinar you still have questions, feel free to leave them at Clarius and I will answer them. Or if later on, if you have any questions, you can send me a direct message on LinkedIn or send me an email to mark@sonoskills.com, and I'm happy to answer all that you want to know.
Thanks so much, Mark. We're going to do a quick demo, but before I get to that, please use the Q&A. Make sure you give Mark all of your excellent questions. I know there's a lot more out there to come, and we will get to those before the top of the hour. And then I wanted to just do a quick demo on what this looks like for me, and maybe you can help talk me through it, Mark. I am certainly not an expert at shoulder musculoskeletal ultrasound like you are. So I'll kind of maybe take it through a couple of the basics as a quick maneuver just to review some of the things you covered. That's okay?
Yeah, sure.
Okay, so I've got here the L15 on a shoulder preset, and it's fired up. And as far as we know, this is a healthy model. I'm scanning in front. I like to scan like you do from behind, but we're going to kind of work with what we have here. So I'm going to start on the anterior humerus here, and this is always where I start my scans. And I saw that it's what you do too to identify the bicep tendon here in the groove between the tubercles.
Yes,
right?
Great.
And this is like you scan, so you kind of went, let's get some depth here, down into the bicep belly, which I don't routinely do, I guess, if patients don't have a lot of pain. And maybe that's because I'm seeing them only really in the acute setting. But I do love how you kind of go up and proximal into the rotator interval, which we did a whole webinar on that before. So
yes,
if you want to know more, yeah. So that's the interval here, right? Where you see the tendon, and it's tricky. I see a lot of people who are learning musculoskeletal ultrasound think maybe that's fluid because it's dark. So you really need to do the sweeping of the transducer to make sure you're getting the tendon and not fooled by anisotropy of the tendon and think that it's fluid or a tear.
Yeah, and keep the transducer a little bit oblique, then it's even better to visualize yes, that's better. And a little bit more to proximal, and then you end up at the rotator interval. So that's great.
Great. Yeah. Okay. And then, so you were doing some dynamic assessment here of the shoulder. I've always kind of done more of the dynamic assessment coming up. So we're going to coming oblique here, and we'll get, there's the acromion here and the humerus. Let's see if we can get, we'll take the arm back to identify supraspinatus here, right? And the insertion. And then to do the dynamic assessment, you're really kind of coming up to that acromion here, right?
Yeah, so if you
seeing, let me see with the tendon. Let's get the tendon back in view. There we go. And maybe a little over.
Yeah, and a little bit less abduction, so relaxed starting position, and it really unfolds the supraspinatus, and then from there you can make the abduction.
Right, there we go. And so now we kind of do a dynamic, go slow, and watch that humeral head really duck underneath. So you're looking for, I liked how you kind of identified the structures there, looking for calcification or thickening, and predicting even, oh, that's not going to fit, or that's going to cause a lot of pain going under. Yeah. Yeah, my positioning here is a little awkward. I like behind was yeah, maybe we could try that. Yeah. Kind of coming from behind. It's certainly more ergonomically advantageous to come from behind. Yeah. And then do the motion. Nice. Great. Great. So I don't see too much pathology in that shoulder.
Yeah, this looks like a healthy specimen. A little bit bursal effusion, but nothing to worry about.
Right. This is not in a dynamic state, but here we have, we're rotating the humeral head, and this is the supraspinatus, and we see this discontinuity here in the rotator cuff.
Yes,
would you say
that's a nice example?
Right at it's right next to the interval, it looks like, with loss of that continuous tendon, suggestive of a tear. We need to know a little bit more about the patient and how they're presenting to really identify. And then lastly, we wanted to show this quick example of an impingement. It's a short clip, but here we have the acromion on the side, and you can see all what you had referred to as the cortical irregularity of the humeral head here, that it's highlighting in the scan. And this is a patient who's trying to abduct their shoulder, and they're really, you can watch it in real time, essentially bonking against the acromion, probably in the setting of a tear that is causing instability there. It's a really short clip. It's hard to really assess the full depth. Yeah. But you can watch as it replays. Is the person trying to abduct their shoulder, and they just can't get the humeral head deep underneath. The acromion is getting stuck there in real time. Yeah, so these are the kinds of studies that really highlight, the dynamic integration beyond just the static, where things like MRIs even can't really capture that dynamic nature to people's injuries and pathology. Great. Well, now that we've covered that, please keep using the Q&A. We're going to get to those at the top of the hour here briefly, and I'm just going to hand it back to Janez really fast.
Thank you so much, Dr. Frankel, for the live scanning. That was so much fun. And thank you, Dr. Schmitz, for your ultrasound protocols and best practices for imaging the shoulder. We are going to have a live Q&A session, so please do use the Q&A tab to ask your questions. But before we open up the floor to those live questions, we have a question for you, a quick poll. We'd love for everyone to continue on their journey in bringing handheld ultrasound to their practice. So please do complete this poll to let us know if we can provide further information. Do click on as many options as apply. Pricing and availability does vary by region, so feel free to request a quote and pricing. You may opt to speak to one of our experts about the advantages of wireless ultrasound. If you'd like to discuss scanner features, please select that option. You can book a virtual one-on-one demo with our experts to see the new Claris HD3 in action in a highly interactive session. And we can send you more video tutorials for MSK Ultrasound, so you may select that option as well. Please do go ahead and select as many options as you wish. While you complete the live poll, I'll take a minute to introduce you to the Claris HD3, the world's only third-generation line of portable ultrasound scanners, now 30% smaller, lighter, and more affordable. Claris HD3 delivers best-in-class wireless ultrasound. Our linear scanners are unrivaled for near-field and high-resolution musculoskeletal imaging and procedural guidance, with an easy-to-use app powered by artificial intelligence and connected to the cloud. Today, you saw how Claris supports a confident diagnosis with high-resolution imaging of muscles, joints, ligaments, tendons, and cartilage, both at rest and in motion. The secret lies in each scanner with not one or two, but 8 beamformers, 192 elements, and AI that together deliver the image quality only found in compact systems, but at a fraction of the cost, representing 85% savings. And with AI replacing complex knobs and buttons, it's as easy to use as your smartphone. So you can quickly diagnose MSK injuries, guide management, and also use it for safe ultrasound guided procedures like PRP injections. Claris is also wireless, freeing up space with zero footprint for ultra portability in a variety of settings. You get free movement with no wires getting in the way, which also makes Claris so much faster to clean, disinfect, and you can fully encase it in a sterile bag. Only Claris delivers linear scanners with an ecosystem that includes free apps for iOS and Android devices for unlimited users. Available with our membership, Claris Cloud is used to easily capture and manage unlimited exams from anywhere. Your membership also includes in-app Claris classroom videos with experts like Mr. Schmitz and onboarding with a Claris clinician to build your skills. Claris Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. And with your membership, you also get our advanced MSK package that includes dedicated MSK presets. And in the USA, it features the FDA-approved MSK AI that automatically identifies, highlights, and measures the thickest section of tendons in the foot, ankle, and knee. We'll now close off the poll in 3, 2, 1. Thank you. If you did ask for more information, we'll get back to you in the coming week. Our last poll is actually an invitation to pre-register and save your seat so you can join us for the next webinar in our MSK series with Dr. Schmitz entitled Assessing the Distal Bicep Tendon, an 8-step ultrasound protocol. Please do complete this poll to save your seat for our October webinar, and we'll send you a confirmation email in the coming days. I'll give you 3 more seconds to save your seats. 3, 2, 1. Wonderful. Well, I'd like to now welcome back Mr. Schmitz and Dr. Frankel to answer your questions. So please do use the questions icon in the menu bar to ask your questions for our great clinicians. We do plan to stay for as long as it takes to answer all the questions. So please stay with us past the top of the hour if needed. Dr. Frankel, can you please moderate for us?
Sure, yeah, happy to. Great, lots of good questions to jump in here, Mark. The first is, how much do you do with management in terms of some of the complications? Do you do any procedures?
Yes, so I do diagnostic and interventional ultrasound, so mainly corticosteroid injections, ultrasound guidance. So that is what I do. I work in a radiology department, and also have a collaboration with the orthopedic surgeon in the hospital. And what we do is we see patients. They first go to the X-ray, then they go to the surgeon, then they come to me for an ultrasound assessment, and then I talk to the surgeon. Is there a surgery needed? Yes or no? If not, is there a injection needed? And then I will place the injection right away.
Oh, great. Great. So what would you say are the most common injections that you do?
I do a lot of AC joints, lots of Bursa, subacromial Bursas, and also the glenohumeral joint. Glenohumeral joint with capsular problems, frozen shoulders, and all three of them, they are very rewarding injections, making patients really, really happy. Yeah.
Yeah, I agree. That kind of aligns with my practice. One of the questions here is, which approach, if you're injecting the glenohumeral joint itself, do you take an anterior, posterior approach?
So I don't take the anterior approach. I think it's a little bit with the neurovascular bundle really close. It's sometimes a little bit dangerous. So I take a dorsal approach, and dorsally you could do it in two ways. You could have a medial to lateral approach, or a lateral to medial approach. I first started with lateral to medial, so going over the humeral head towards the labrum and the joint. But then I switched to medial to lateral. So first passing the joint and then going towards the humeral head, and that one is much easier and also much safer, and you avoid sticking into the labrum. So I would definitely suggest that one as a preferred approach, dorsally, and then from medial to lateral, the needle in plane technique.
Medial to lateral in plane. Love it. Well, yeah. We should demo that maybe at a future webinar.
Yeah.
Great. This is a common question we get a lot, and I get a lot when I'm talking about shoulder ultrasound, is how to differentiate partial versus full thickness tears and grading partial tears. Do you have some guidance on how to do that?
Yeah, so that's not always that easy. So I understand really this question, and this is something that a lot of sonographers struggle with, especially when they're new to ultrasound or starting to learn this in the rotator cuff. So yeah, so we can classify several tears in the rotator cuff. You have the partial tearing either on the bursal side or on the articular side, or in the mid tendon. Then one step later in the process, if things get worse, you get a full thickness tear, but partially width. If it gets worse, it completely tears. And if it gets worse, more tendons will be affected and you have a massive rotator cuff tear. So if you look at the consensus statement made by the European Association of Radiology, they will say that for complete tearing and full thickness partial width tearing, ultrasound is the preferred imaging tool. So it's really easy to see those tears with ultrasound. But if it comes to partial tearing, then ultrasound scores similar to MRI, or maybe even less, because sometimes it's really hard to differentiate between a partial tear and a severe tendinopathy. So it's a matter of ruling in or ruling out, and it's not always easy to do that. And well, so you can be honest about that as well in your reporting. So if you hesitate or you're not sure, just write it in your report, and then probably if they really want to know the answer, they need to make an MRI as a follow-up. So don't guess. I would say just be honest in your reporting.
Yeah, that's good. Do you ever perform suprascapular nerve blocks? You showed the suprascapular notch. Is that in your procedural repertoire?
I did it, but it's not that I do it that common. It's also not something that I see that commonly in practice. I do see it maybe once per month, but it's not that I see it on a daily level. So I have a little bit less experience. But if you know the trick of visualizing the needle in plane, and if you know your anatomy, where the safe zones are, and where the zones are which are more at risk, then it's really easy to target a structure. Fluid is your friend, and if you want to target this anechoic zone near the nerve, then it's really easy to target that.
Yeah, I would add in the emergency setting, I have combined that now with a glenohumeral injection for adhesive capsulitis frozen shoulder, and have found that it improves patients' outcomes, pretty good. So I kind of do a combined approach for most of my patients who have severe pain.
Try that. That's a good advice.
Yeah, I read some literature about it where they were just doing the suprascapular, and I said, well, why not do both? If one thing that does come up though is what are the harms? We talk a lot about procedures on a lot of these webinars, and we work with an orthopedic doctor who's done a lot of webinars, Dr. Hirahara, and he talks about from his perspective, I guess you're consulting with the surgeon because there is a risk of if they're going to undergo a surgery for their rotator cuff tear, steroids can actually impair the healing post-operative. Is that the case in your practice where they'll caution against doing injections if there's potential surgery?
Yeah, so we always discuss the patient together. So this is really a good thing because I learn a lot from a surgery perspective, and he learns a lot of radiology perspective. And sometimes we're discussing, is it better to do an injection or do the surgery or just doing a physiotherapy program? So this is always, we try to scale up. So if possible, only physiotherapy. If it's not likely to succeed, or if physiotherapy has failed, we're going to step up to do the steroid. And if that doesn't help, then we are going to advise a surgery. And so we always step up if needed, but always try to start with the least impact to the patient, or with at least invasive impact.
One thing a lot of people want to know is, can you assess the labrum, like a slap lesion, or how reliable is ultrasound for that?
Yeah, so the labrum is really well to see in the anterior approach, inferior approach, and posterior approach. I would not say that labrum, that ultrasound is the golden technique to score the labrum. So let's be honest about that. I think that other medical imaging techniques are a little bit better about that. But if you're working in primary care and you don't have access to medical imaging in your practice, and you are scanning the shoulder and you're looking at the shoulder joint for fluid, and you might see something strange to the labrum, I would say dorsal labrum, anterior labrum, and inferior labrum, you can definitely say something about it. At least this is normal or not normal. I'm going to refer this patient. If it looks not normal, I'm going to refer the patient to, for example, a surgeon, or maybe for additional scanning underneath in an MRI. If it comes to the superior labrum, which is interesting with slap lesions, it depends on the patient. Some patients you can see. I would say most patients you cannot. So this the clavicle is a little bit blocking the view. It's a little bit too. The angle is not optimal. So the 12 o'clock position is hard to scan.
Let's see, we're getting through most of these questions. What would you say, I think this is a bit broad and maybe hard, but could you speak to sort of best practices for bursitis, or is it more nuanced? I would think it's more nuanced depending on where the bursa inflammation is and what the symptoms are.
Yeah, there's a lot to tell about the Bursa. That's a whole topic for a new webinar. Yeah, so expect the Bursa in several locations. A lot of people think that you can only see it near the supraspinatus, but if you're scanning the shoulder protocol, in fact, you can see it almost in every step. You can see it near the biceps, you can see it near the subscapularis, the supraspinatus, infraspinatus. You can see it underneath the coracoacromial ligament. So it's there. If it's there, there is most cases a anechoic effusion. And this effusion makes the Bursa really easy to see. As long as you don't see anything, the Bursa is probably okay. But if you do see a bursal change in thickness, then it's obvious, and the bursal effusion is there. Bursal effusion, anechoic change, is due to an acute problem. And sometimes this is mixed with some hyperechoic, some wide proliferation of the synovial tissue. So that is more an inflammatory bursitis, proliferative bursitis. So that's also easy to see. Sometimes not so easy to see is a chronic bursitis. In chronic bursitis, you don't see any anechoic effusion, but the bursal blades, the peribursal fat tissue itself, the white lines, which are the boundaries of the bursa, they are thickened due to chronic friction of the bursa. So not so much effusion, but more thickening of the hyperechoic bursal tissue. So those are maybe a few points which may help you in clinical practice to start scanning those bursas. But there's much more to tell about it because it's a big topic.
Yeah. How often do you see tears in subscap, and how do you recognize them? I'm used to more kind of supraspinatus.
Yeah, definitely. So the supraspinatus is your first one, but I would say the infraspinatus is the second, third place is the subscap, fourth is teres minor. But I would say that the subscap and the infraspinatus, they are pretty close together if it comes to statistics. It is definitely a tendon which is underestimated in rotator cuff tearing, because the subscapularis is a little bit difficult to scan, because it has these internal tendon fascicles. It has a little bit of a heterogenic echogenicity, and then you are starting to doubt: is it a partial tear? Is it a tendinopathy, or is it just normal anatomy? So it takes a little bit more experience to visualize and to diagnose a subscapularis tear. So that's one point. Another point is that the subscapularis is really broad, and most people stick in one spot and they don't scan the full subscapularis, and missing actually the regions which are more at risk. And yeah, so subscapular scanning is a little bit more difficult. Supraspinatus is very clinical relevant, happens a lot, but it's also really easy. So it's much easier.
I think that's why I like it. Yeah. Last question I think here is, do you differentiate stages of calcification, or is it just a, yes or no, absent or present?
You cannot differentiate the stage based only on ultrasound. You can detect the type of calcification, type 1, 2, or 3. So type 1 meaning it's a very hard calcification with a strong acoustic shade underneath. Type 2 is a softer calcification with a faint shade, and type 3 is a soft calcification with no shade, so the softest type of calcification. And that if it comes to ultrasound-guided interventions, I think that for a type 1, you would do fenestration. So people who are not known with the concept, it's sticking the needle into the calcification and causing debris of the calcification, whereas in type 3, the softer calcification, you would go in with the needle and try to wash it out, so a barbotage, lavage technique. So the type of calcification is interesting to know, but the exact stage, is it the formative phase, or is it well, I forgot the 4 stage names, but that's really the literature has shown that that's not so much to you cannot say anything about that with ultrasound.
But it can help guide your intervention depending on what you see or what it is. Yeah, great.
Correct.
Okay, well, I think that's most of the questions we have here. Thanks so much for everybody's time and for sticking with us. Janez, I'm going to hand it back to you here.
Thank you so much for all of your wonderful questions. It made for a very lively Q&A session. Many asked for more information. On our Claris website, in the Education tab, you'll find access to a library of on-demand webinars and Claris classroom video tutorials that showcase MSK imaging best practices and ultrasound-guided injection techniques. We also encourage you to sign up for training with our friends at SonoSkills. Also, you will all receive a PDF copy of the slides that were presented today and a recording of today's webinar as well. I'd like to thank Mr. Schmitz for sharing his best practices, and a very big thank you to all of you for joining us today. We hope to see you again on October 25th as we explore the 8-step ultrasound protocol for assessing the distal biceps tendon. In the meantime, keep scanning, and we hope you have a wonderful rest of your day. Thank you so much for joining us.
Have a good day. Bye-bye. Thank you.